acquired thrombotic thrombocytopenic purpura, or ATTP for short, and I think for obvious reasons. Hopefully I've got that out okay. In our discussion, we'll be learning about the clinical care and lived experience from both those living with ATTP and the caregivers who support them. I'm Nicola Miller, the Creative Director at Rare Revolution magazine, and in the background working on the tech today, I'm joined by my colleague Rebecca Penzer. Today's session is sponsored by Sanofi, and as a couple of housekeeping points, please do take advantage of our great panel by using the Q&A, and we'll come to some questions at the end. So please do drop them in the Q&A box and we'll endeavour to answer as many of them as we can. Any that we can't get to at the end of the session, we will endeavour to go back to the panel with and bring them to you as feedback after. The session will also be available to revisit on demand, and we'll circulate the links to that in due course so you can catch up with it after. Today I'm really thrilled to be joined by a very knowledgeable panel who will be popping on to join us. Dr. Shruti Chaturvedi, Associate Professor of Medicine at Johns Hopkins University, who among other things specialises in the care of adults with ATTP. Claudia Caminiti, a patient advocate and caregiver. Anis Banks, a patient advocate living with ATTP. Joe, the founder of the TTP Network, which is a patient support group for patients and families. Daniel Anibal Garcia Diego, president of the Spanish Federation for Hemophilia, FedHemo, and the vice president and head of global public affairs, rare diseases and rare blood disorders at Sanofi, Jean-Pascal Roussy. So welcome everyone. We're really thrilled to have you all on today. Please do feel free to pop your cameras on. We're going to kick off the session with a brief presentation from Jean-Pascal to really help set the scene. So Jean-Pascal, if I can pass to you, please, and we'll let you take it from there for a moment.
Excellent. Well, thank you, Nicola, and good morning and good afternoon, everyone. So I'm Jean-Pascal Roussy, and I'll be representing Sanofi today at this webinar. So first, I'd like to thank Rare Revolution for your commitment to raising awareness of rare diseases and also for creating that platform for rare disease champions to be heard. I also want to thank the panelists for your participation in today's conversation and also for accepting to share your experiences and your stories with ATTP. So Sanofi is a global healthcare company driven by one purpose: we chase the miracles of science to improve people's lives. We know that there's more than 350 million people around the world that are affected by diseases that are so rare that they are difficult to diagnose and treat. So at Sanofi, we are committed to delivering, discovering new options for people living with rare disease and rare blood disorders. So with that said, I'm very excited about the webinar and the conversation to come, and I'll pass the bar back to Nicola.
Wonderful. Thank you so much, Jean-Pascal. So as you said, obviously diagnosis and management of treatment is really important. So I'd like to really start the discussion there. So if I can come to you first, Dr. Chaturvedi, can you explain how most people receive a diagnosis with ATTP and what the challenges are for healthcare professionals in making an adequate and a correct diagnosis?
Of course. So, this process for the patient usually starts when they start experiencing some symptoms and show up to receive medical care. Now, where they show up is important because I could either show up to the family physician with symptoms such as headache, nausea, abdominal pain, just not feeling well, or they may be having more severe symptoms such as, a very severe headache, stroke-like symptoms, or being unconscious or having, changes in their mentation. When they show up for care, the doctor will often get a blood count because that is a common investigation to get, and that's when the ball gets rolling, because what's most commonly seen is a low platelet count, usually with a low overall blood count or anemia as well. And if it's the primary doctor, they will often get sent to the emergency department at that point because the platelet count can be quite low, and then someone has to think of calling a hematologist or someone who will review the blood smear because that's the next critical step. Sometimes that happens very quickly, sometimes it takes some time. And then you're relying on the medical staff that is seeing this patient to be aware of the diagnosis and have the expertise to diagnose it. And that's where things get challenging because, like I just pointed out, the presentation or the symptoms that people show up with are very varied. They can range from no symptoms at all, just blood count abnormalities, all the way to an extremely sick patient who needs to be in the intensive care unit. Symptoms can be what we call non-specific, like a headache, which can have many causes, or abdominal discomfort, which can have so many causes. And even the blood changes that we see, for example, the low platelets that are so important, there are many other causes of low platelets that are a lot more common. So what happens at this stage in many cases is that there is the potential for misdiagnosis. For example, a lot of people get the diagnosis of what's called ITP, or immune thrombocytopenia before they are truly diagnosed with TTP, simply because more people have heard of ITP and seen ITP, and that's just more on the radar. Because it's such a rare disease, many doctors may never have seen a case in their lifetime unless they specialize in it. It may not be the first thing they think of. The second barrier is that the diagnostic test, we do have a test that can diagnose TTP. It is what we call the ADAMTS13 activity, and if that's very low in the correct clinical setting, that essentially diagnoses the condition. At least in the United States where I practice, not every hospital has that test available within that hospital. They often send out the sample. So if you have it available, you can often have the test result in a few hours making the diagnosis. But if you are relying on that test and you have to send it out and it takes a week to come back, that can lead to delays in diagnosis, which unfortunately are very problematic for patients because A, they're not getting diagnosed, but the delay can also lead to really bad outcomes. Which is why we actually urge everyone that we speak to not to really wait for the test result to treat somebody if it might be TTP. So those are the major issues that are faced by patients and providers while making the diagnosis. A rare disease that looks like it could be a lot of other things. Not thinking about it because you haven't seen it much or you're not thinking about it all the time. And then the diagnostic test not being readily available to most people, at least in our country.
Absolutely. And obviously you mentioned there the importance of improving outcomes with swift treatment. So kind of a two-part question here. What is the current pathway for a person that's presenting with symptoms that has then got a diagnosis? And what are the long-term psychological impacts of that care pathway?
Of course. So the ideal situation would be that someone, presents, for example, to the emergency department and gets some blood count. Someone notices that the platelets in the blood count are low and a blood smear is reviewed rapidly. Now, if that shows red cell fragments, what we call schistocytes, they're quite a sensitive marker that someone might have ATTP. We will, of course, send off testing with ADAMTS13 and look for other possible causes of what's going on. But in an ideal world, they would get plasma exchange very quickly within a matter of hours, which means that someone would be available to put this essentially a very large IV into either the groin or the neck. That it's like a dialysis catheter by which one can receive plasmapheresis or plasma exchange, which is one of the standard treatments where we essentially take out someone's plasma and replace it with normal plasma. And that's another barrier here because some hospitals are equipped to do it with staff that they have on site. Other people have to either send the patient to a facility that has the equipment and the staff that can do this, or wait for someone to come in and do that. So there may be some delays there as well, and the patient may need to be transferred to another site. But in general, we would hope that everyone gets this treatment within the next 2 to 6 hours of showing up, which I think happens in half of the cases or less.
And is that a one-off treatment or is that a repeated treatment?
That is a treatment that people are supposed to get every day in addition to other treatments that we then add on until their platelet count normalizes and stays normal for a couple of days.
Right.
So that is something that should be started quickly, and there are often barriers to that in terms of making the diagnosis, but also having the equipment and staff available all the time, and then needs to be continued every day. But if we take a step back and I put myself in the patient's shoes, which I know Ms. Banks can do better than I. You show up somewhere not knowing what's going on with you. This is probably a condition you have never heard of before. And a stranger tells you that I'm going to put this big IV in your neck or big central line and going to exchange your entire body's plasma. And if I don't do this, pardon me for being blunt, but if I don't do this, you will die. I cannot even wrap my head around how traumatic that is. And even now, when I follow my patients, particularly in the first 6 to 12 months, there is so much stress and anxiety and essentially post-traumatic stress disorder equivalent. And I completely understand why, and I don't think I would have been able to go through it. So the psychological impact has got to be immense.
Yeah, I can see, Ines, you're really reacting to that. I can see that. So, that really resonates with you. So it'll be interesting to hear a bit more about your journey. Before we do that though, Joe, could you just kind of circle back so obviously that's a really interesting perspective. And I'm wondering, how did things differ in Europe? Is the situation with regards to diagnostics in those early days different in the UK and Europe?
It's very similar actually, and it has been very similar until probably the last 18 months when we've commissioned 9 specialist centres, so 9 hospitals that have evidence that they've got the right equipment, access to the right departments, an ICU, an apheresis team 24/7, specialist haematologists with experience of dealing with TTP. So those 9 sites, those 9 hospitals are now designated specialist centres. And the protocol is that if a patient presents at A&E, for example, and exactly as the doctor describes, it looks like it could be TTP, it should be treated as if it is TTP, and they should be then transported to the specialist centre, and they should start apheresis within 4 hours, and at the very maximum no later than 8 hours from the time of presentation. So that's a very strict protocol. Now, sometimes if they're very sick and they're in perhaps a very isolated place, that's not possible. So there is a shared care protocol that sits alongside that. But yes, that's how it should happen. But all the challenges are exactly the same. I would say you're relying on people in the A&E setting to consider TTP. You're relying on the patient to recognise that they need to go to A&E, either via their primary care, their GP, or presenting themselves. So there's lots of opportunities for there to be a delay, which obviously has poorer outcomes.
And there's a real sense of a ticking clock here, isn't there, which will bring
Absolutely.
us, we talk later about that awareness piece and how important that is. Dr. Chaturvedi, if I can come back to you then, in terms of patients presenting with an acute situation, what does that post-acute care look like?
When you say post-acute, you mean when leaving the hospital?
Yeah.
So, we're hoping that at this point of time, their platelet count has recovered, they are doing well from the symptomatic standpoint, and they will usually be discharged on some treatment which is aiming at suppressing the immune response that led to TTP in the first place, those antibodies. So there's discharge on immunosuppressive treatments. And particularly in the early days after discharge, we're watching our patients very closely to make sure that they don't have a recurrence of TTP. We call it an exacerbation when it occurs within 30 days of stopping therapies such as plasma exchange. So in that period of time, in the first month or so, at our center at least, we will be seeing patients about once a week, checking their blood work once a week as we help them taper off their immunosuppressive treatments or complete them as our outpatient. And at the same time, along with the blood count for the platelets, we're also checking their ADAMTS13 levels that give us a sense of, how they're doing in terms of recovering ADAMTS13 activity, because the more you recover activity, the lower the chance of having a recurrence. Around the 6 to 8 week point, people are usually in what we would call a clinical remission and hopefully an ADAMTS13 remission as well. I tend to follow my patients once a month for the next couple of months as well to make sure there are no lingering acute issues. But after that point of time, we continue to see our patients and get blood work every 3 months, where we are doing actually 3 things. One is get the blood count and check for symptoms that might indicate a true relapse for which you need to re-hospitalize somebody. To monitor that ADAMTS13 activity, because if that starts to go down even without symptoms or low platelets, we can offer immunosuppression treatments to prevent a relapse. And my goal is that no one should ever relapse if we can avoid it, because every relapse comes with the risk of really bad consequences ranging from strokes to death. And the third thing that we've started doing more in the last 5 years or so is checking in with our patients in other ways to look for the sequelae, unfortunately, of TTP, whether there are issues with functioning in daily life because of what our patients will call, for example, a brain fog or cognitive decline. We actually have a program where we screen for issues such as anxiety and depression, and also do everything that we can to optimize their health in other ways, particularly their heart, brain, and blood vessel health, so cardiovascular health, because patients with TTP seem to be at slightly increased risk of complications related to that system. So in the beginning, it is a question of getting them to a point where they're in a remission from their TTP. And after the 3 to 6 month point, we're focusing on relapse prevention, but also trying to take care of and minimize the long-term issues.
Yes. Okay. Excellent. Yeah, so it's a really complicated process, I guess, isn't it? That really important monitoring of the patient after that acute phase.